All right, welcome to case study 72 on module 4 for renal failure. So this is going to be in your Harding clinical case studies book. Yeah, let's go. So you've got a couple other ones that are assigned to you guys, but I thought this one would be the most helpful for us to go through. So KB is a 32-year-old woman being admitted to the medical floor for fatigue and dehydration, very common in your renal failure patients, okay? While taking her history, you discovered that she has diabetes. That's a red flag, right? She's been on insulin since she was 8. She has undergone dialysis for the past 2 years because of end-stage renal disease. So your initial assessment of KB reveals that she is thin, pale, slightly drowsy, her skin's warm and dry, she's got poor skin turgor, mucous membranes are dry, vital signs are 140/88, pulse 116, respiratory 18, temp 99.9. She tells you that she's been nauseated for 2 days, so she has not been eating or drinking. She reports severe diarrhea, and she's got the following blood chemistry results. So let's get to those. All right. So take a look at these guys. If you don't have the normals for these things memorized, you need to know them. So of these labs, which ones are the most concerning? So sodium, right, it's a little high. The potassium, we would expect that in renal failure to be high. 6 is really high. BUN creatinine, we would expect those to be high. Glucose is high. All right. So what aspects of your assessment support her admitting diagnosis of dehydration? So let's go back to that. So she's got that high sodium, right? She's slightly drowsy. Her skin is warm and dry. She's got poor skin turgor. Mucous membranes are dry. She's a little tachycardic, right? She's got a little bump in her temperature. She tells you that she's been nauseated and not eating or drinking. She's had diarrhea. So all of those things would point you in the direction of dehydration. So let's talk about 2 possible causes for KB's low-grade fever. So like I just said, you can have a low-grade fever with dehydration. She could also have some kind of viral illness. You know, there's all sorts of viruses that can cause nausea, all sorts of stomach things that go around. She could have a UTI, or she could be septic. And remember, they can have trouble with their immune response. So we note that she has a AV fistula in her left arm. So what is an AV fistula? So if you go back to our lecture, that's when you create this section in usually their lower forearm, where you combine the flow of the veins and arteries to create this little area where you can do dialysis, right? And she has it so she could do her dialysis. And when we're assessing a fistula, remember you fill the thrill. So you palpate and you feel the thrill, but you auscultate, you hear the bruit. So we would look at the fistula, we would palpate it, we would auscultate it. We would assess for signs of bleeding or infection. So bleeding would be, of course, bleeding. And they can bleed significantly. You've got some high flow, blood flow going through those things. And they used to come into the ER sometimes when after dialysis, they couldn't get them to stop bleeding. And then infection would be standard infection signs, redness, drainage, swelling, pain, those sorts of things. And the thrill and the bruit are present because of the turbulence that we have from the mixing of the blood over the artery and the vein. And those are all things that are normal for your fistula. Okay, as you continue the assessment, you notice that the unlicensed assistive personnel comes in to take KB's blood pressure. The unlicensed assistive personnel places a blood pressure cuff on KB's left arm. What, if anything, do you do? So can you take any blood pressures or do any blood draws or do anything to the arm with a fistula? The answer is no. So you respectfully would tell your unlicensed assistive personnel that, hey, we can't do anything on that arm. And then whatever your procedure is, if you have like sometimes places will put like a special armband on the arm, or they put like a thing over the head of the bed that says like limb alert, or they put it on the door that says you can't do anything to that arm. And then educate KB as well. Be like, hey, this is your fistula arm. You need to keep it safe, so that you empower her, because you can't be there with her all the time. Okay, so we get some labs. We're going to ask, are these normal? And if they're not normal, what is abnormal? So we've got a problem with our RBCs. We've got a problem with our hemoglobin and hematocrit. So anemia is common in end-stage renal disease because you have the problem with erythropoietin. And erythropoietin is what stimulates the bone marrow to produce red blood cells. So by nature, they're going to be anemic. And also dialysis can lyse the red blood cells, so chew them up. So that can make those H&H levels go even lower. So KB's physician notes that she's anemic, which is most likely the cause of her fatigue, and we already kind of talked about why. So we answered your own question. Good job. She's sent for dialysis because she's got the potassium of 6, right? She really needs the dialysis. Over the next 24 hours, her nausea gets better. She can eat normal. While you're helping her with her morning care, she confides in you that she doesn't understand her diet. I just get blood drawn every week and meet the dialysis dietitian every month. I just eat what she tells me to eat, and it's so hard. So what are special nutritional needs for her? And let's talk about 4 components of the diet. So remember, she's diabetic, so she needs to be on a diabetic diet, and she needs to be on one that's compatible with dialysis. Okay, so make sure that you know with everything that we talk about, dietary restrictions, and renal ones are kind of funky, so make sure you spend some time understanding this. So depending on what her labs are, they can adjust her diet on a weekly or monthly basis to meet her renal requirements. So common adjustments for your renal patient include reducing protein intake, which is different than other things, limiting fluid intake, so it's sort of like your heart failure patients, restricting phosphorus and sodium, magnesium, potassium, because they're not going to be able to process those electrolytes correctly, right? And then making sure she's getting enough calories, enough vitamins, and enough minerals. So pretty challenging to be on a renal diet. Which of these statements about fluid intake for dialysis patients is correct? Select all that apply. So take a look at those. So 1 is right out, right? We already talked about them having a fluid restriction because they have problems with regulating fluids because their kidneys aren't working right. B, dialysis patients need to restrict fluid intake to water only. That's not accurate. C, fluids are restricted to 1,600 mils plus the amount equal to the previous day's urine output. That is correct, actually. Number 4, a fluid is anything that's liquid at room temperature, so coffee, popsicles, ice cream. Yes, that is true. So D is true. So 3 and 4, both true. And then 5, hypertension may occur if large amounts of fluids are retained between dialysis treatments. That's correct too, right? If you've got too much fluid in there, that can create fluid volume overload, and that can cause hypertension. All right, patients in renal failure have the potential to develop comorbid conditions. Identify 5 potential problems, determine how you would assess the problem, then delineate nursing interventions and patient education strategies for each. So I want you guys to spend some time on your own working through this about renal failure and what comorbid conditions they can develop, okay? So really dig into this problem. This is a way for you to review the renal content and really study this and make some connections in your head to how it applies to different other conditions. But we'll mention a couple here briefly. So remember, they have trouble with electrolyte imbalance, right? Specifically potassium imbalance. So whenever you have problems with the potassium, remember your heart gets really upset. And so you can have dysrhythmias. We talked about fluid volume overload being a problem, which causes hypertension. They can be anemic, which we talked about earlier in this case study because of the destruction of their cells during dialysis, and then the whole problem with erythropoietin and not producing enough red blood cells. They can have seizures because of the imbalance in sodium, which we mentioned in the lecture, and then problems with fluid volume overload. So there are more. And go back through and identify those problems, how you would assess for those problems, which is really important, what you would do for interventions, and how you would educate to try to prevent those problems. So this is a really good way to work through the material and help it cement in your brain. So take a picture of this and do some little extra credit there. And then our outcome of our case, she's discharged home. She goes to her local dialysis center 3 times a week. She also keeps her appointments with her dietitian and says that she's feeling so much better. So this is a pretty quick case study this week, but make sure you spend some time looking at the other ones. Really highly encourage you to get together with a study group or a tutor or both. To work through the other case studies. We'll cover some more information on renal during our review tomorrow night at 7 o'clock. And hope you guys can make it, and hope you were all safe during the weather this week. And I will hopefully see you guys in class on Monday. Good luck on your test.